So today's grand rounds is going to be about pathophysiology of varicose veins and venous ulcer formation. So it's very much tainted on the mechanistic side. There's not a whole lot of clinical information, but I think it's important for us to understand the basic foundations of the underlying mechanisms in order to direct our clinical therapies. So today's talk is broken up into two categories. We're going to look at the macrovascular disease, which is varicose vein formation, and then we're going to get down to the skin level, looking at the microvascular changes. So we all know that there is a difference in the anatomical structures of our arteries and veins. The main difference being that arteries have a very large media used for contractile purposes, and comparatively the media in veins is much thinner, and that veins also have unidirectional valves in them that are one cell layer thick. So there have been many theories proposed as to what causes a varicose vein. Right now, the majority of people think that varicosities are genetic, and that there's some other environmental and hormonal factors associated with it. But you can also get some acquired forms, primarily from deep vein thrombosis. But pregnancy and female hormones definitely contribute to it, especially if you have a genetic predisposition to it. So primary disease has an unknown etiology, is absolutely responsible for at least 70% of all cases of reflux. However, the other 30% are associated with a history of a deep vein thrombosis as well, especially on the deep side, and also the cause of post-phlebitic syndrome. So the real question is, why do people progress from something as simple as a small reticular vein to then a varicosity, to these huge varicosities, and then on to worse disease? Well, right now there is a two-hit theory for varicose vein formation. The first part of it is thought that there is valve damage leading to reflux and venous hypertension, and that there's also vein wall damage and contractile abnormalities. Now, which comes first is unknown, but the two definitely have to go hand in hand in order for our patients to develop varicose veins. So let's look at valve damage for a second. So hopefully this video will play. It didn't play, but anyway, this is a photograph that was sent to me by Dr. Caprini, looking at valve function. You can see that the valve leaflets oppose, preventing reflux of blood. And then this was a movie that was supposed to show the valves opening and closing with respiration. And this movie doesn't work either. So this movie was supposed to demonstrate that the valve leaflets here don't oppose. So this is someone who's got a varicosity with valve leaflets that don't come together. And this is what reflux looks like on the duplex scans. And then this was supposed to be another movie showing what a damaged leaflet looks like with respiration after a clot. So we know that the valves don't work, and we know that the valves get damaged when there's a DVT because they're only one cell layer thick. But what causes the vein wall abnormalities? So this is an electron micrograph taken of a normal vein. This is one of the first studies I did when I was done with my fellowship in the lab. And here what you see is what the normal contractile anatomy of the vein is supposed to look like. These black arrows here are pointing to smooth muscle cells. These smaller arrows are pointing to the extracellular matrix. And the one thing that you can tell here is that all of the fibroblast cells are in longitudinal. There's a very appropriate architecture here. And this is what the vein looks like when it's normal, and its primary function being contraction. When you get a blood clot, though, what happens is there's an injury to the endothelium. This injury causes uploading of cell surface markers, which then causes fibrin and blood to then attach to it. And then when that happens, this activates macrophages and monocytes. And the theory is that these macrophages and monocytes then release cytokines that cause vein wall damage. So this is another electron micrograph of a varicose vein. And you can see here that the normal vein wall architecture has been lost completely. These smooth muscle cells, which used to be longitudinal, you had a very prominent nucleus. You could see the contractile fibers in it, are now completely destroyed. This is called vacuolization, where these little white vacuoles appear inside the cell. And then the other part is you can just see here that the wall is completely filled with collagen fibers. So they've lost the normal contractile architecture. And this is what it's called a secretory architecture. And it's been associated with contractile abnormalities. What actually causes this transformation is still currently unknown after all this time. And then if you look up at a close-up, so the previous slide showed all of this collagen formation between the cells. And this is just a high-powered magnification of what those collagen fibers look like in the vein wall. So this slide was sent to me by Peter Henke. They had a baboon model of which they induced a DVT by ligating the inferior vena cava. And what they showed was the progression of vein wall damage as the clot starts to organize. So this is the non-thrombosed inferior vena cava. This is the clot that they've induced. And you can see here, these white arrows show the thin wall of the vein. Then at 8 days, you can see here how much the vein wall has thickened as the clot starts to contract. And then finally, at 21 days, when the clot is fully contracted, you see the intense inflammatory reaction and the vein wall thickening. So Peter Henke and Tom Wakefield have done a great deal of work looking at thrombus-induced vein wall damage in their labs at the University of Michigan. I like this slide a lot because this is a slide by Joe Raffetto. What he did was he took great saphenous veins, proximally, distally, and in normal patients, and then he also took them in varicose vein patients. And what he did was he put them in a model in which it measured contractility. And basically what this shows is the white part here is normal veins. And then the bottom here is these varix veins from the proximal, mid, and distal part of the great saphenous vein. And they all contract abnormally to various stimulants. So they stimulated them with norepinephrine, epinephrine, angiotensin, and none of them contracted to the same degree as a normal great saphenous vein. So in addition to the anatomic abnormalities, there are physiologic abnormalities associated with contractility in these abnormal varicosities as well. So this was supposed to be another movie file which showed blood flowing through this vein. But the main point I want to show about this picture is that what I tell patients all the time is that when we place them on anticoagulants, the clot doesn't melt, that your body pokes holes in the clot and it forms new channels. And this is what a recanalized great saphenous vein looks like. And this white stuff you see here is essentially collagen within the lumen. And then the black area are the reformed channels, which is why the veins never function as they did normally, because you always have some intraluminal debris from this chronic scar tissue that's intraluminal. Now, what about genetic factors? So this study in 1994 is probably the one study that demonstrated that there is a genetic component to varicose vein formation. Now, what they did here was they actually examined all of the parents of patients who presented to their office with varicose veins. They didn't call them on a phone. They didn't do a survey. They actually examined these patients. And what they found was that if your mother and father both had varicose veins, there was greater than a 90% chance that you were going to get varicose veins. If one parent had it, there was a 25% chance in males, but a 62% chance in females. And if neither parent had it, there was a 20% chance you could still develop it, indicating that there may not be all genetic factors associated with varicose vein formation, and that there may be some environmental factors that actually trigger the gene to become active in these patients. So what this indicates is that varicose veins, the gene is an autosomal dominant with variable penetrance. And what that means is it gets transferred to every generation, but it probably requires environmental factors. So in women, it's female hormones in pregnancy. In men, it tends to be morbid obesity and heavy labor. Now, there's been a lot of work over the past, say, 5 to 10 years trying to identify the gene that causes varicose vein formation. There are several candidates that have shown some interest, but none of them have definitively shown that an abnormality with this gene always causes a varicosity. And I think it's because it requires environmental factors. And that's why it's been so difficult to try to find the gene that's caused this. What about the microvascular changes? Well, once you get the macrovascular changes and you start to get reflux, the prevailing theory has always been that you have abnormal blood pressure in the venous system. And what this diagram shows here is that when you break up the valves, instead of having small columns of blood, you have larger columns of blood. And we all know from physics that if you have a tall column of blood, that the greatest amount of weight is at the bottom of the column. That's why when people go scuba diving, you get the bends, because you have the weight of all the water above you. But when you have functioning valves, it breaks up that column, and that's why we don't get venous hypertension. So obstruction and reflux causes venous hypertension. So that venous hypertension gets transmitted to the skin and the dermal capillaries. So this is another electron micrograph of biopsies that were taken of venous ulcer patients from a study that was done at the University of Zurich. And what this shows is these are red blood cells, and these are interendothelial gap junctions. And here what you see on the right panel is a red blood cell that's being pushed through this gap junction into the interstitium. Now, what that means is red blood cells move by passive motion, right? They're not like macrophages where they can move on their own. So once a red blood cell leaves the circulation, it doesn't re-enter. And what we've learned over the subsequent years is that the iron within the red blood cell is extremely, extremely irritating to skin, and it causes an intense inflammatory reaction associated with chronic inflammation. So what happens is then these circulating white cells, then as they're tumbling along the capillary surface, they're always sensing the endothelium. So if there's an upregulation of inflammatory mediators, the white blood cells sense that upregulation on the cell surface, the glycocalyx, if you will, and then it attaches to the cell surface, and then they start to move into the interstitium so they can deal with whatever the inflammatory agent is. So what ends up happening is you get this very classic picture on electron microscopy of what was originally termed the fibrin cuff, but now it's called the perivascular cuff. And what you see here again is thickening of the vein wall, but more importantly, you see this intense collagen deposition that's surrounding the vein wall. So it's theorized that this fibrin cuff, if you will, or extracellular matrix cuff is so thickened, so it acts basically as a wrap, if you will, so that the capillary doesn't explode. So on biopsies, when you see this, this is the sine qua non of chronic venous insufficiency. And the other thing that you see in this electron micrograph at the very top here at 12 o'clock, this is a circulating macrophage. And you can't see, but the tail of it got cut off back here. But this is a long tail, and the macrophage is actually making its way over to this lymphatic vessel to go into the lymphatic, because once it's removed its debris, it goes back into the lymphatic system. And this is another macrophage that's already in the lymphatic system. So we did some studies looking at TGF-beta1. And what we found here, these arrows here are showing these black dots. TGF-beta1 stains black on this immunohistochemistry. And over here, what we did was we tried to identify, well, what are these cells here? And these cells stain positive for fibroblasts. So what we see is that TGF-beta1 is binding to these fibroblasts, and it's causing a change in their phenotype. So this electron micrograph also demonstrates this cell here. This cell is a mast cell full of granules. So one of the things that you hear from our patients all the time is that they have intense itching here. And part of the reason for that is that when you get this chronic inflammatory stimulus, mast cells surround the perivascular cuff, and it's theorized that it's the release of histamine that causes these itching in patients. So what I do when patients complain of this itching, I just merely put them on an antihistamine, or I give them Benadryl cream and have them put that over the area of itching, and it usually ameliorates the itching. This photomicrograph on the right, what it's showing is these are actually macrophages, and you can see these little black granules here. Those are staining positive for TGF-beta1. So here you see a capillary, you see that thick perivascular cuff. Here you see a macrophage that's actually attaching to the cell surface. Here you see some that are in the process of moving through the cuff, and here you actually see some macrophages that are moving through the cuff to go into the interstitium to try to deal with the inflammatory stimulus that pushed them there in the first place. So what do we think is happening here? So this little cartoon, what it's showing is that you have circulating macrophages that are sensing the endothelium. These are upregulated proteins on the cell surface of the glycocalyx, and then the macrophages sense them, and then they leave the circulation and they go into the interstitium. They go to the inflammatory stimulus, which here is red blood cells and iron, and they start to clean up the debris. But what happens is iron stimulates these cells, and it changes them into an M1 phenotype. And we're going to talk more about what that is in a moment. But the M1 phenotype is a destructive phenotype. This is the macrophages that are producing cytokines that want to destroy the stimulus, so usually an infection or some kind of debris, so that it can then absorb it and take it out and go into the lymph nodes. But then the macrophage releases cytokines, and the two big ones are TGF-beta1 and tumor necrosis factor alpha, as well as free radicals. Well, we know that the TGF-beta1 binds to the fibroblasts, and what this does is it changes the phenotype of the fibroblast. So instead of the fibroblast producing collagen to help with repair, it turns it into a contractile myofibroblast. And what a myofibroblast does is that it pulls the wound apart. So one of the theories I had when I was doing more of this basic research is that the contractile properties of the fibroblasts in vein patients, chronic venous insufficiency patients, is higher than a normal patient. And this leads to abnormal tension with the eventual destruction of the cell surface keratinocytes, and then a wound forms. So up until 2011, that was kind of one of the prevailing theories, because we also had no good animal models, but there was a lab in Germany that asked, well, are there potentially other mechanisms that may result in this wound problem, and also in other deformities to the fibroblast and into the wound healing process? So one of the first people to look at this question was Bill Marston at the UNC Chapel Hill. And what he did was he took the next step of a study that I did, and he biopsied patients with venous ulcers. And what he did was he biopsied them before he put an Unibut on or compression, and then he biopsied them after they healed. So here what this shows is this little bar down here at the bottom is normal patients. So they biopsied healthy patients, and they looked for the presence of various cytokine markers. And then they did a biopsy of the ulcer patients before and after. Now here, this is looking at MMP8 and MMP9. And what the before shows is that these matrix proteins were elevated, but with compression, it basically starts to decrease and go down to normal. And essentially every cytokine that they looked at had the same phenomenon except for one. So interleukin-1 beta, interleukin-8, interleukin-12, these are all pro-inflammatory cytokines, and they were all elevated before compression therapy. And once compression therapy was added, and then the ulcers healed, all of these pro-inflammatory cytokines started to decrease and drop to normal. Same thing with TNF-alpha, interferon gamma, except for TGF-beta1, which increased with wound healing. And you would expect to see this because the TGF-beta1 cytokine is a pro-wound healing cytokine. So what the theory is by adding compression to these ulcer patients, you're cutting off the venous hypertension, which is leading to the extravasation of the red blood cells, and you're cutting off the iron from being dumped into the interstitium. And then all these pro-inflammatory cytokines are returning to normal because the body is being allowed to heal the wound. So this was one of the first studies to actually try to figure out what the mechanism of compression therapy is. Then we did a very sophisticated study in our basic science lab looking at contractility properties. And what we did here is we looked at NC is the normal patients, and then 2, 4, and 6 are class 2, class 4, and class 6 patients. So this is the control. We looked at contractility of the fibroblasts. And as you can see, as your Sieve class increases, the contractility of your fibroblast increases. Then we had a viral vector that we added just to show that the vector didn't interfere with contractility. And then what we did was we added a protein called RAS, which is a signaling protein. And what we found was that when you add RAS to the fibroblast, it essentially inhibits contractility. TGF-beta, on the other hand, stimulates contractility enormously. But when you add RAS to the TGF beta, the RAS inhibits the effect of TGF beta. So one of the things that we had proposed was that there's abnormal signaling within venous ulcer patients that the TGF beta protein is unable to overcome. And then what the other thing that we looked at as matrix metallic proteins, because there was some theory that, well, maybe MMPs are abnormally regulated in venous ulcer patients. And essentially what we found is that's not true. There's really no major difference between the MMP proteins, regardless of your SEEP classification. So this paper, in my opinion, is probably one of the breakthrough papers of the 21st century. This was a very sophisticated basic science investigation looking at macrophages, but more importantly, looking at phenotypes of macrophages. So what they did was they looked at patients who had venous ulcers and they compared them to people who had pressure ulcers. And over here, the blue stain here is iron. So you can see in the venous ulcer patients, there's an intense amount of iron staining, whereas in the pressure ulcer patients, there is none. The other stain over here to the far left is looking at activated macrophages, and the green is the activated macrophage, and you can see here there's very little green. And then finally, on this bottom left-hand panel here, they looked at the two together, and what you can see is that their activated macrophages in iron are much, much higher in the venous ulcer patients than in the pressure ulcer patients. So then this group came up with the hypothesis is that there's two distinct phenotypes for macrophages. So much like in AIDS, where you have T1 helper cells and T2 suppressor cells, in venous patients or in humans, you have an M1 phenotype and an M2 phenotype. The M1 phenotype is pro-inflammatory. That's the destructive phenotype that goes after the infections, that goes after the debris in a wound. You have to do this so that you clean the wound up first and then switch over to the M2 phenotype, which is wound healing and wound remodeling. Well, what these investigators found was that when you add iron, iron causes the macrophage to assume an M1 phenotype, but not only that, these macrophages produce TNF alpha. So the TNF alpha stimulates these peroxynitrite compounds, which basically lead to tissue destruction, but it also damages DNA, which leads to cellular senescence. So what was really interesting in this experiment, though, was they added a TNF alpha blocker. Now, some of you may have heard of Enbrel. That's the medication that's used to treat psoriatic arthritis. Well, Enbrel is a TNF alpha blocker. It's called etanercept. When they added Enbrel to these macrophages, it blocked TNF alpha production, and it allowed the M1 macrophages to assume an M2 phenotype. And it also blocked the iron effect. When you added desfuroxamine is an iron chelator. It absorbs iron from the interstitium. So these two together promoted an M2 phenotype and increased wound healing. And they demonstrated this in an animal model. So what they did was they took mice and they put these wounds on the back of the mice. And in here, this is the sham experiment where they just added dextran. This is a wound that has iron in it. And as you can see, at day 10, it still hasn't healed completely. This panel is iron, but they added desfuroxamine. And you can see that the iron chelator promoted wound healing. And then finally, when you added etanercept, which is the TNF alpha inhibitor, to those wounds that had iron in it, it also promoted wound healing at a faster rate. So this is evidence in an animal model that perhaps if we were doing something to these ulcers, like applying an iron chelator or maybe injecting etanercept around the edges of the wound ulcer, we may be able to promote wound healing in some of these venous ulcer patients. So potential therapeutic uses of this basic science information. So compression to reduce toxic cytokines. Obviously, we know that compression therapy works. It's been the standby for over 2,000 years. Literally, I mean, we've got records that wound bandaging helps these wounds heal. To me, it's interesting to think that Enbrel might actually help wound healing in venous ulcer patients. Iron chelators, to me, is a no-brainer. We had something that we can take a 4x4, soak it in the iron chelator, put it in the wound, and then put the Uniboot around it, I think that might also help. There's still a lot of work to be done with growth factors. Most of the clinical trials looking at growth factors for venous ulcers haven't shown any benefit, but I'm sure it's just the way that the trials were designed. And then we need to do more work in the laboratories to see if we can identify mechanisms of converting M1 phenotype macrophages to M2 phenotype macrophages. So this is just a summary of what we have, what we think is the mechanism for venous ulcer. You get venous valve damage or outflow obstruction leading to ambulatory hypertension. You get red blood cell extravasation. You get iron overload of the macrophages leading to TNF alpha production, and then a change and the development of macrophages into this M1 phenotype. This M1 phenotype produces TNF alpha and other free radicals, which cause damage. And then it's a cycle that perpetuates itself and continues to make the ulcer worse or prevent it from healing. So this summary is actually a good cartoon demonstrating what we know so far as the mechanisms for venous ulcer formation. And then finally, one last word about compliance. This study by Mayberry from 1991 has never been reproduced, but it's the only study out there in which somebody actually called the patients to find out if they were wearing the compression stockings. And what they found was that the patients who were compliant with their compression therapy had a lower recurrence rate as opposed to the non-compliant patients. So in conclusion, for varicose vein formation, we have the two-hit theory of vein wall valve damage, as well as vein wall thickening, leading to contractile abnormalities, leading to venous hypertension, and then all the microvascular changes that happen as a result of that venous hypertension. So thank you for your attention. And I'm going to stop right here. And at this point, ask if anybody has any questions.
Good morning, Peter. It's Philip. How are you?
Good.
When we were younger, we used to take these people to the operating room and do wide debridement and just take all of these mediators out. We don't do it as much anymore. Would you comment on that?
So I used to do the same thing. I still think there's a role for surgical debridement, but I think we have a lot more tools in the toolkit now. So for example, I routinely see ulcer patients in my practice, and they're dirty and they're huge. And what I usually do for them is I just put full strength betadine into the wound. And believe it or not, betadine just kills everything in the wound, including the normal cells. But the whole purpose is to sterilize it. So I think if that doesn't work, then they need to be surgically debrided. But for the majority of those patients, you have other ways that you can kind of clean the wound. That doesn't necessarily mean taking them to the operating room. And listen, I was taught the same thing, Philip, that you need to kind of debride it back to normal tissue. I don't know how true that is now, knowing what the mechanisms are. So between infection, having that coating or that biofilm that Bill Marston talks about, I think if you get rid of that and you do things to kind of stimulate the macrophages into the wound healing phase, you may not necessarily need to take them for the wide debridement as much. But the other thing that I think also helps now is because of Bill Marston's work. I'm very quick to put somebody on oral antibiotics now, because if I think there's Pseudomonas in the wound, even though it may not be infected, but if it's got colonization, so between the betadine and the antibiotics, for the most part, you can kind of get that dirty appearance cleaned up and then start your normal kind of wound care stuff to get them closed.
Yeah, I still debride, not liberally, but I don't hesitate. What topical antibiotic mixture are you using these days?
I don't use a topical antibiotic. I give them an oral antibiotic.
Yeah.
because you need it to kind of get in there systemically, especially around the wound edges. So anything that has Pseudomonas coverage, what I found is it's the Pseudomonas, not the staph, that really prevents the wound from closing.
Always was. How about, last question, how about, I still like using, and I think it works reasonably well for short term, is Silvadene.
Yeah, I would discourage you from doing it. Silvadene has side effects to it, and I think it doesn't work. I think it's something that people, especially a lot of these wound care centers, just give patients to put on it just to make them feel like they're doing anything. but it really doesn't have the broad spectrum antibiotic coverage that you need. And listen, it may help in burn patients, but in my opinion, it doesn't do anything in venous ulcer patients. The other thing that we used to do when I was a resident, we used to have these silver impregnated gauze pads. We used to put them in there. What we found is that it actually made things worse.
Yeah, I remember those. Thank you.
Yeah. All right. Well, listen, thank you everyone for getting up early on Friday for listening to this basic science lecture. Everybody have a great weekend, and I'll talk to you guys soon.